Assalamu alaikum. So today our lecture that we're going to do is eczema and psoriasis. Commonly people mistake them for similar disease because they look a bit similar, but once you get to know the morphology and the clinical manifestation, it's not difficult to differentiate it. Now, what is eczema? Eczema comes from the Greek name boiling, like tiny vesicles or bubbles that are present in the early stages of the disease. And dermatitis is basically inflammation of the skin. It's a broader term, but some people confuse it for eczema and dermatitis. Dermatitis is a wider spectrum. That is, eczema is a part of dermatitis. All dermatitis are not eczema, but eczema is dermatitis. How to classify eczema? Two sources, exogenous and endogenous. Exogenous is basically contact dermatitis, irritant and allergic, and the photocontact dermatitis. And the endogenous ones are those that occur in only specific people who are prone to develop that type of eczema, like atopic dermatitis, seborrheic dermatitis, discoid, pomphylix, gravitational, asterotic, neurodermatitis, juvenile plantar dermatosis, and naphthalene dermatitis. There's a long list. First, we will see what is the pathogenesis of eczema. Pathogenesis is similar, involving the similar inflammatory mediators, prostaglandins, leukotrienes, cytokines. Helper T cells sometimes are activated by superantigens, for example, from Staph aureus. Then the epidermal cytokines produce spongiosis, and their secretions by the keratinocytes, which elicited by the T lymphocytes, irritants, bacterial products, and other stimuli, they all add up to the development of eczema. Histologically, there is an acute phase and a chronic and an intermediate. Acute it's a wet type of weeping lesion with spongiosis and intraepidermal vesicles. The chronic stage has less spongiosis and vesication and acanthosis, hyperkeratosis and parakeratosis in the chronic most stages. And the intermediate one is that which has a little bit of features of the acute and a little bit of features of the chronic. Acute clinically is weeping, encrusting, blisters, vesicles, redness, papules, swelling, and a little bit of scaling present. Chronic is less vesicular with exudation, more scaly, pigmented, thickened, lichenification, and fissures present. Complications, heavy bacterial colonization, especially in the seborrheic variety, in the atopic, and the nimolar variety. Local superimposed allergic reaction to medicaments can provoke dissemination. It can interfere with the sleep, with the normal work, with the sport activities, any other activity. Now the differential. The first differential that comes in mind is psoriasis. Sharply marginated, very scaly, involves the knees and elbows. Then scabies, to some extent, not exactly because the lesions are different. Itchy contacts, face spared, burrows, affects nipples and genitalia. Lichen planus, it has oral lesions, and the papules are basically violaceous or flat topped. Then the fungal infections. Fungal infections are specifically annular type of lesions with a clear center. Palmoplantar pustulosis, obvious pustules are present on the palms and soles. Angioedema and erysipelas usually swollen on the face. Now, what are the investigations? Patch test, photo patch test, total and specific IgE antibodies, and the RAST. Treatment for the acute weeping eczema, we have to give rest to the patient and liquid application. Basically, for a wet lesion of any skin disorder, you have to dry it. And for any dry lesion, you have to moisturize it. Non-steroidal preparations, then aluminum acetate solution, which is a cooling agent, saline or tap water, and soaks followed by a smear of corticosteroid cream or lotion. Potassium permanganate, commonly called as pinky. It dries up the lesions. Calamine lotion, another soothing agent. Magenta paint. Wet wrap dressing, that is bath followed by some steroid application, covered with dressing. Subacute eczema, intermediate type, steroid lotions or creams, depending on what are the manifestations. Then bacteria, bexitracin, fusidic acid, mupirocin, neomycin as needed. The chronic eczema has steroid and ointment base, ecthamol, zinc prenol based. Nothing stronger than 0.5 to 1 milligram for infants or children. Mild potency, then moderate potency, and the potent. Actually, it's very important to know that steroids are very good treatment agents for inflammatory diseases, but the quantity, the amount, the site, the age of the patient, and the severity of the disease all are important to take into account which type of steroid is applied for how long. Systemic therapy, systemic steroids, for example, prednisolone, hydroxyzine, doxepin, trimeprazine, systemic antibiotics. That is steroids, steroid-sparing agents, um, antidepressants, systemic antibiotics, anti-allergics. They all are used. Common patterns of eczema. Now, first we come on to the exogenous types, that is the contact dermatitis. 80% of dermatitis is this irritant contact dermatitis, mostly industrial, usually on hands and forearms. Acute reaction elicited after brief contact, commonly by detergents, alkalis, and solvents. It's important to know that irritant contact dermatitis is often of the similar reaction in most individuals. It may lead to loss of work. Differential has to be allergic contact dermatitis and the atopic dermatitis. Patch test with irritants is not helpful and may be misleading because it is going to give a false positive in 99% of cases because irritant is an irritant. Treatment, we have to avoid the irritants. We have to use protective measures, barrier creams, topical steroids, emollients, and of course, change of job if that's possible. Then allergic contact dermatitis. Mechanism is delayed type 4 hypersensitivity. Previous contact is needed. It's specific to one chemical usually. Remote areas may be affected. Sensitization is persistent indefinitely. That is, once it develops, it takes a little time to develop. It needs previous contact. It needs memory cells to be formed. But once sensitization is there, repeated exposure to the same allergen, even in a lesser quantity, is going to produce a reaction. Most allergens are simple chemicals that, when bind to protein, become complete antigens. Areas involved are eyelids, external auditory meatus, hands, feet, depending on which area of contact is present. High-risk individuals are hairdressers, working in flower shops, dentistries, and others as well, farmers, etc. Common allergens: chrome, nickel, cobalt, lanolin, neomycin, rubber, poison ivy, and oak. Jewelry, bra clips, jean studs. These are common allergens. Patch test is recommended, and a patch test is done for allergic contact dermatitis. We have to avoid the allergens, topical steroids. We have to add ferrous sulfate to the semen to reduce its water-soluble chromate content so that it becomes less allergenic. Now, this is a picture, and this is a case of, you can see these atopic dermatitis. Atopy means out of place. This is a state in which there is excessive production of IgE. And this occurs in response to common environmental allergens. Atopic patients usually have a triad of allergies: asthma, hay fever or the allergic rhinitis, and the allergic dermatitis or the atopic dermatitis. So it's a triangle and may or may not have food allergies. 75% eczemas, atopic dermatitis begin before 6 months of age, and then some after 5 years, and gradually this percentage decreases. And 60 to 70% of patients clear by the early teens, unless exposed professionally or occupationally with similar allergens. Atopic dermatitis has 3 phases: the infantile, childhood, and the adult phase. Infantile, vesicular, weeping lesions which start on the face. The childhood ones are leathery, dry, excoriated, usually the cubital fossa, the popliteal fossa, flexures, wrist, ankles. Adults have proper lichenification. We did the lichenification in the terminology chapter. Go through that so you can understand what lichenification means if you do not remember. More widespread, Why dermographism is striking. We did both white and red dermographism when we did urticaria and terminologies. Cardinal feature is itching. The diagnostic criteria must have chronically itchy skin, plus three or more of the following: history of itching in skin creases, history of asthma or hay fever, generalized dry skin or xerosis, visible flexural eczema, onset in the first 2 years of life. Complications: bacterial infections, mycoplasma, herpes simplex, molluscum contagiosum. Prick test used to show type 1 reaction. Treatment: explanation, reassurance, counseling is very important. Avoid exacerbating factors, topical steroids, tacrolimus, which is potentially a steroid sparing agent, topical cyclosporin type, calcineurin inhibitor, sedative antihistamines, antibiotics, ultraviolet therapy, and cyclosporin itself. This is a picture of atopic dermatitis. You can see the overall skin as well as the flexures. You can see the atopic dermatitis in this child. The face is involved, but look at the skin all over the body. Look at the action that the child is doing. The child is pinching his skin because it is so itchy. Another picture of atopic dermatitis. Then this is a different type of dermatitis, which is an endogenous type again. This is seborrheic dermatitis. If you can appreciate, there are scales present in the scalp, on the forehead, in the eyebrows, eyelashes, more on the T-zone of the face, but even on the cheeks and the ears. Common eczema of the hairy areas showing characteristic greasy yellowish scales. Red scaly exudative or dry scale or intertriginous areas are affected. Affect scalp, ears, eyebrows, face, pre-sternal area, armpits, that is axilla, umbilicus, groins, may be familial and affects those with dandruff. There may be overgrowth of Pitrosporum yeast, may be early sign of AIDS, mainly affects adults, usually recurrent. It occurs after puberty, that is, it's under the influence of the hormones. It may be associated with other dermatological disorders like furunculosis or superadded candida infection. Treatment: topical imidazoles, sulfur, salicylic acid, topical steroids, ketoconazole shampoo. Another picture of seborrheic dermatitis. Seborrheic dermatitis again. Now, discoid or nummular eczema, common endogenous eczema, affects limbs of middle-aged males but may occur in children as well. It's basically a reaction to the superantigen of Staph aureus. Multiple coin-shaped vesicular crusted itchy plaques are present. That is why it's called as discoid. Treatment: topical steroids and antibiotics. You can appreciate the disc-like nature. Then popfolics, recurrent bouts of vesicles or blisters on the palms, fingers, or soles of adults, even teenage. Cause is unknown, but may be provoked by stress or heat, or maybe sweating and allergy to nickel. Recurrent infection and lymphangitis may be present. It may follow acute tinea pedis. Treatment is antibiotics, aluminium acetate, the cooling agent, potassium permanganate and pinky, and the steroids. This is a picture of pemphigus. Then gravitational stasis eczema, usually accompanied by venous insufficiency. It's the hemosiderin deposition which gives the lipodermatosclerotic picture. This term is used to the skin findings associated with venous stasis and usually occurs on the lower limbs. Chronic patches of eczema on the lower legs. Patient may become sensitized to the local antibiotics or to preservatives in the medicated bandages. We have to eliminate the edema. We have to treat with the topical steroids, the zinc cream, and of course, we have to treat the underlying venous insufficiency. Otherwise, this treatment is not going to work out. Asterotic eczema or the dry eczema usually occurs as senile eczema, itchy eczematous patches, plaques on the lower legs of elderly. Contributory factors: dry skin in old age, low humidity in winter, central heating, diuretics use, hypothyroidism. These all add up to the effects of this asterotic eczema. Then treatment: steroids, restrict bathing, restrict use of too much hot water, daily use of emollients. Excuse me. This is astatotic eczema on the limb, lower limb. Then localized neurodermatitis, which is lichen simplex. Single fixed itchy lichenified plaque on the nape of the neck in women, legs in men, and anogenital area in both sexes. That is the approachable or easily reachable areas. This is basically neurodermatitis because it is more of a psychological issue and the patient gets relieved and enjoys the mild itch that occurs. Skin damage from repeated rubbing or scratching as a result in response to stress. It becomes a habit. Treatment topical steroids with occlusion, tranquilizers with little effect. This is the neurodermatitis on the nape, neurodermatitis. Then juvenile plantar dermatosis. As the name suggests, it is a dermatosis that occurs on the plantar aspects in children. May be related to modern shoe and socks lining with subsequent sweat gland blockage, toxic shock syndrome. Forefoot and underside of toes become dry, shiny with deep, painful fissures. It's very characteristic to see that the forefoot is involved and the back is clear. There are no lesions present on the mid to sole of the feet. Use of cork in sole and shoes, cotton or wool socks, emollients, ectomol, and steroids are used for treatment. And the napkin or diaper dermatitis, irritant in nature, aggravated by waterproof plastic pads, feces, and urine. Most moist, glazed, sore erythema of the napkin area, sparing the skin folds. Okay, the skin folds are spared in this. This differentiates it from seborrheic eczema. In the seborrheic eczema, the skin folds are involved. Candida superinfection is common and may present as erythematous vesiculopustules on the periphery. For the treatment, keep this area clean and dry. Topical zinc, castor oil, silicone, mild steroid antifungal combination is effective. The child should be allowed to be free of napkins as much as possible. Now I come on to the second topic of today. This is psoriasis. When you don't know what is eczema, you often mistake psoriasis for eczema and vice versa. Now, psoriasis is a chronic inflammatory papillosquamous disease characterized by salmon-colored plaques with silvery white large scales and histologically by hyperproliferation of the keratinocytes, increased dermal and epidermal inflammatory infiltrate, and angiogenesis. This is a basic definition of psoriasis morphologically as well as histologically. Now, what happens in the pathogenesis? There are two types of psoriasis. First is hereditary HLA complex 2-6, early psoriasis and severe variety. Type 2 is sporadic. This usually occurs later and is a milder variety. Causative factors, genetic factor, as I mentioned before, the HLA, then autoimmunity, T cells, Th1, 17, 22, and many others. There are raised interleukin 2, 8, 15, 17, 22, 23, TNF alpha, and interferon. Then there are some environmental triggers, stress, infections, skin trauma, medications, obesity, smoking, and alcoholism. If you remember, cell cycle of a normal keratinocyte is 28 to 45 days. In psoriasis and some other disorders of keratinization, the cell cycle shortens to as less as 4 to 5 days. That is, the cell from the basal layer reaches the stratum corneum in just 4 to 5 days. That is why there is hyperkeratinization and thickening of the skin. Now, there are some certain associated disorders and complications. Psoriatic arthritis, inflammatory bowel diseases, both Crohn's and ulcerative colitis, immune-mediated, for example, thyroid diseases, type 1 diabetes, alopecia areata, vitiligo, metabolic syndromes like truncal obesity, hyperlipidemia, hypertension, insulin resistance, chronic obstructive pulmonary disease, chronic renal disease, cardiovascular disease, and fatty liver. That is, if you see, it's not just a pure disease of skin, it involves a lot of other organs, rather almost all the other organs of the body. This is first type, guttate psoriasis. Guttate is raindrop, cheetah, teardrop. Acute onset of raindrop-sized lesions on the trunk and extremities, often preceded by streptococcal pharyngitis. Occurs in the teenage. Another example of guttate. The large plaque is just minimized. Inverse of flexural psoriasis. Erythematous plaques in the axilla, groin, inflammatory, inframammary region, other skin folds. It may lack scaling due to moistness of the area. More erythema is present. Inverse psoriasis, more pictures. Pustular psoriasis. It can present in two ways. Psoriatic lesions, plaques with pustules or plain pustules. It is often triggered by corticosteroid withdrawal, potent steroid withdrawal. And when generalized, pustular psoriasis can be life-threatening and needs hospitalization. These patients require hospitalization along with a dermatologist consultation. Palmoplantar psoriasis. This variety involves only the palms and plantar aspects, and the rest of the body is perfectly normal. It may occur as either plaque or pustular variety, functionally very disabling for the patient because the patient cannot walk. It's painful. The patient cannot perform his daily chores, his job, occupation, all are affected. The skin lesions of reactive arthritis are similar and they occur on the palms and soles and quite indistinguishable from that of this type of psoriasis. Reactive arthritis is Rita's disease. Then you have to look for other associated findings of the Rita's disease to differentiate this. Then psoriatic erythroderma involves almost the entire skin surface. The skin is bright red, associated with fever, chill, and malaise. Like pustular psoriasis, hospitalization is sometimes, not always, but depends because the skin is not able to perform its normal functions and you need to hospitalize the patient. Now, how would you describe these lesions? What type of psoriasis does this patient have? This patient has chronic plaque, silvery white scales. That is the salmon colored plaque with large silvery white overlying thick scales. This is plaque psoriasis, which is the most common type of psoriasis. Well-demarcated plaques with overlying silvery scales and underlying erythema. Chronic plaque psoriasis is typically symmetric and bilateral. The plaques may exhibit Auspitz sign, which is when you remove the scale, there are tiny pinpoint bleeding points, and Kovner phenomenon, which is lesions induced by trauma. We did this phenomenon in the terminologies as well. And no, we did it in the viral infection lecture. Then more examples of plaque psoriasis. These all are plaque psoriasis typical sites, lower back, sacrum area, and knees. Now, which type of psoriasis is which? A is guttate psoriasis, B is inverse of flexural psoriasis, C is the chronic plaque psoriasis, and D is the palmoplantar scaly psoriasis. What are the basics? Plaque psoriasis is most common, affecting 80 to 90% of patients, and they have mild to moderate disease, localized or scattered lesions, covering less than 5% of the body surface area, BSA. 20% of moderate to severe disease affecting more than 5% of the body surface area, may be affecting crucial areas such as the hands, feet, face, and genitals. It's a hyperproliferative state resulting in thick skin and excessive scaling. Skin proliferation is caused by the cytokines which are released by the immune cells. Systemic treatments of steroids target these cytokines and the immune cells. Psoriatic onychodystrophy. Now, psoriasis does not only affect the skin or the joints and other systemic involvement, it also causes proper nail involvement. Nail psoriasis can occur in all psoriasis subtypes. It can occur with the skin psoriasis or it can occur only as a psoriatic onychodystrophy. 50% are involved. Toenails and 35 finger are more involved. What are the changes? There are 14, 15, 20 changes. But if you just remember 4 letters, P-O-S-T, post, or you can rearrange it as spot, stop, pots, whatever you want to, tops. Pitting, punctate depressions on the nails, nail plate surface. Onycholysis, separation of the nail plate from the nail bed, giving it the oil drop sign, which is the pathognomonic sign of the nail psoriasis. Then subungual hyperkeratosis, which is a normal keratinization of the distal nail bed, giving denting and raised nail appearance, and it's difficult to cut this nail. Tracheonychia. Tracheonychia is rough nails as if scraped with sandpaper longitudinally. These are the four main findings of psoriatic onychodystrophy. Then psoriatic arthritis. Arthritis in the presence of psoriasis. It's a member of the seronegative spondyloarthropathies. Symptoms can range from mild to severe variety. Occurs in 10 to 25% of patients with psoriasis. Can occur at any age, but mostly occurs between 30 to 50 years of age. Usually occurs 10 to 15 years after psoriasis of skin. So it's not difficult to diagnose. It's not related to the severity of psoriasis. If it occurs before the skin psoriasis, then it is difficult to diagnose because the patient does not come to the dermatologist first, he goes to the rheumatologist first. And the rheumatologist often thinks of the other types of arthritis first. Now, there are 5 clinical patterns of arthritis. Most common is the oligoarthritis with swelling and tenosynovitis of one or more hand joints. This variety is like osteoarthritis. Second type is most common is oligoarticular variety. Flares and remission usually characterize the course of the psoriatic arthritis. Then, healthcare providers are encouraged to actively seek signs and symptoms of psoriatic arthritis at each visit. Psoriatic arthritis may appear before the diagnosis of psoriasis, as I mentioned earlier. If psoriatic arthritis is diagnosed, treatment should be initiated, number one, to alleviate the signs and symptoms of psoriasis, then to inhibit the structural damage, and to maximize the quality of life. Diagnosis is based on clinical judgment, specific pattern of joint inflammation, absence of rheumatoid factor, the presence of skin and nail lesions of psoriasis, and the clinician himself in making the diagnosis of psoriatic arthritis. These are some examples of psoriatic arthritis. The first variety is arthritis mutilans. You can see the fallen off digits, desquamation of the overlying skin, as well as the joint swelling and deformity of both feet. Then swelling of the proximal interphalangeal joints of the second to 4 digits, distal interphalangeal joint of the second digit. This is the small joint involvement variety like the rheumatoid arthritis. Since the psoriasis is localized less than 5% body area, topical treatment is appropriate. First line is hypotensive topical steroids in combination with calcipotriene, which is vitamin D analog. Other topical options are tazarotene, salicylic or lactic acid, tar, calcineurin inhibitors like tacrolimus. Factors that influence the type of treatment. What is the age of the patient? Type of psoriasis, plaque, guttate, pustular, erythrodermic, which type? Okay. Site and extent of psoriasis. Localized is less than 5% of BSA. It is also called as PASI, which is psoriasis area severity index. Generalized, diffuse, or more than 30% involvement. So if it is just a localized involvement, then it's better to treat the patient with topical treatment because the systemic treatments themselves have other side effects. So why affect the patient systemically if he has less than 30% involvement? What previous treatment the patient has had? Other medical conditions, that is comorbids. Patients with localized plaque psoriasis can be managed by primary care provider as long as he knows the basics. Psoriasis of all other types should be evaluated by a dermatologist. Now, this is a general chart showing medication, the uses in psoriasis, that is which type of psoriasis the medication is used for, and the side effects. Topical steroids are used for the plaque type psoriasis, but side effects include skin atrophy, hypopigmentation, and stry, so you have to keep that in mind. Calcipotriene, vitamin D derivatives, tazarotene topical retinoid, salicylic or lactic acid, which are keratolytic agents, coal tar, which is very good for plaque type psoriasis, calcineurin inhibitors, which are off-label, which have off-label use for facial and intertriginous psoriasis, but they all have their side effects to you. So you have to keep these in mind, and you also have to tell the patient. Then topical medications for psoriasis are more effective when used with occlusion, which allows for better penetration. A bandage, glove, or socks placed over the medication can serve this purpose. Then the systemic treatment in patients with moderate to severe disease, systemic treatment can be considered and should be supplemented with the topical treatment. Many patients with moderate to severe psoriasis are only given topical therapy and experience little success. Undertreating the patient can lead to a loss of hope regarding their disease. Oral steroids should never be used in psoriasis as they can severely flare psoriasis upon discontinuation and can cause the patient to go into pustular psoriasis. Yes, topical are used and gradually tapered, but not systemic steroids. There are three choices for systemic treatment: phototherapy, oral medications, and the biologic agents. Phototherapy, narrowband ultraviolet B, broad band ultraviolet B, or Soranin plus ultraviolet B, PUVA therapy. Oral medications, methotrexate, acitretin, and cyclosporin. These all are immunomodulatory agents, so they are good for treating not only the skin psoriasis, but even psoriatic arthritis. Biologic agents, T-cell blockers, Elifacept, TNF-alpha blocker, infliximab, etanercept, adalimumab, monoclonal antibodies, interleukin 12 and 23 blockers, ustekinumab or secukinumab. So these are targeted and they produce very good results, and the biologic agents are good in that they treat, if it started early, they prevent the development of permanent deformities, because once the deformities are present, we cannot reverse them. We can just arrest their rapidity, and we can just arrest their progress. The choice of systemic therapy depends on multiple factors: convenience, side effect risk profile, presence or absence of psoriatic arthritis, and comorbidities. Systemic treatment for psoriasis should be given only after consultation with a dermatologist. Patient's experience. A successful treatment regimen should include patient's education as well as provider awareness of the patient's experience. Find out the patient's views about their disease. What do they think? Ask the patient how psoriasis affects their daily living. Ask about symptoms such as pain, itching, burning, and dryness of skin. Ask patients about their experience with the previous treatments, how effective they were. It is important to ask patients about their hopes and expectations for treatment. Provide time for patients to ask questions. That is, it's very important. You know the disease, the patient does not. The patient has lots of questions to ask because he is the one who's suffering. Psoriasis is a lifelong disease and can affect all aspects of a patient's quality of life, even in patients with limited skin involvement. Remember to address both the physical and psychosocial aspects of psoriasis. Many patients with psoriasis feel socially stigmatized, especially those having psoriasis in exposed portion of the body. They have high stress levels. They are physically limited by their disease. They have higher incidences of depression and alcoholism. They struggle with their employment status. So the take-home points are: psoriasis is a chronic multi-system disease with predominantly skin and joint manifestations. About 1/3 of patients with psoriasis have a first-degree relative with psoriasis. Different types of psoriasis are based on morphology: plaque, guttate, inverse, pustular, and erythrodermic. Plaque psoriasis is the most common type, affecting 80 to 90% of patients. A detailed history should be taken in patients with psoriasis. Plaque psoriasis is often diagnosed clinically. Nail disease is common in patients with psoriasis. Healthcare providers are encouraged to actively seek signs and symptoms of psoriatic arthritis at each visit. Topical treatment alone is used when the psoriasis is localized. Patients with moderate to severe disease often require systemic treatment in addition to the topical therapy. Systemic treatment includes phototherapy, oral medications, and the biologic agents. Oral steroids should never be used in psoriasis. A successful treatment plan should include patient awareness, education, as well as provider awareness of the patient's experience. Psoriasis is a lifelong disease and can affect all aspects of a patient's quality of life. Thank you.